Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from OTSCA.
This program is presented by Medscape Education Global.
Hello, I'm Hans-Joachim Anders. I'm a professor of nephrology at the University of Munich, and I have a long-standing interest in the pathophysiology of glomerulonephritis and in the management of such patients. I'm excited about the recent developments in this domain and the expanding treatment options, for example, for IgA nephropathy. So it's an honor to welcome you all to today's program entitled The Basis of Success, Recognizing IgA Nephropathy and Promoting Earlier Diagnosis to Facilitate Treatment Initiation. And I'm joined today by Sarah Davis and Peter Bohr. Dr. Davis, would you like to introduce yourself?
Thank you very much. My name is Sarah Davis. I am a primary care physician from Wales in the United Kingdom. I actually trained in general medicine and specifically diabetes before I went into primary care. So I've really carried forward that specialist interest, particularly around diabetes and kidney disease. And I'm really passionate about the role that primary care plays in these disease areas.
Thank you so much. And we are also joined by Dr. Bohr from Aachen.
Thank you very much. My name is Peter Bohr. I am a pathologist working in Aachen, Germany, and I'm leading the nephropathology group there and also digital pathology electron microscopy facility. And we are very much interested in biomarker field and also artificial intelligence in better diagnosing kidney diseases.
Okay, so thanks for being with us today. I think we start out to discuss a bit how common is IgA nephropathy, because as a nephrologist, we tend to think this is a common disease, but the numbers actually tell us that it's not so common and actually fulfills the criteria of a rare disease in Europe and the US. So you can see here on this world map that in the different world regions, there are only a couple of 100,000 people with that disease. And the question is how we can pick them up, because patients with IgA nephropathy have up to 50% risk to develop end-stage kidney disease, and this implies dialysis or kidney transplantation and has a huge impact on the quality of life of patients. Around 10% of patients with IgA nephropathy need dialysis in the upcoming decade. 60% will require a kidney transplant after reaching that stage, and altogether it's the most common form of primary glomerulonephritis, but anyway, a rare disease. And Dr. Davis, what do you think, how often you see IgA patients in your GP practice?
It's interesting, isn't it? Because obviously you're running a specialist nephrology clinic. So to you, it feels like you're seeing it quite a lot. But to me in primary care, where we see everybody, actually, it feels really quite rare indeed. And I think that in primary care, it's just not something that we're very familiar with seeing, and therefore perhaps are just not thinking about it when people are presenting with potential symptoms of IgA nephropathy. And maybe that's something we can work on in raising the awareness amongst our primary care colleagues.
But you're from the UK, and now from the UK we have this fantastic RADA registry, which teaches us a bit about the prevalence and also the natural course of the disease. Could you tell us something about that?
Absolutely. So I was fascinated to read this, as you say, UK cohort observational study from the RADAR registry, so the rare diseases of the kidney registry, where we can really follow exactly what's happening to people with diseases such as IgA nephropathy. And I think perhaps it's previously been seen as a relatively benign disease, but actually the RADAR data tells us otherwise. So we can see here that actually most people will progress towards end-stage kidney disease within 10 years of that diagnosis. More so if they have heavy proteinuria, I believe I'm correct in saying, but even those with lighter proteinuria, so less levels of protein in their urine, we're still progressing towards end-stage kidney disease. So actually, we should not be seeing this as a benign condition. And certainly for me, the idea of trying to pick up these people earlier, to get them to your clinics earlier, where maybe some interventions will help to slow that rate of progression, feels like a really important role that we have to play.
So thinking about how to pick up these patients is a question how they are presenting first, because that will happen at the GP practice, and that's the moment to pick them up earlier. So what do you think, or what you know, what are the primary presentations of this disease?
Absolutely. So for me, I'm thinking about a patient who presents with hematuria that I can't otherwise explain. Now, that can sometimes be tricky because often when we see someone with hematuria, we may think of a urological cause. So perhaps we need to have something like bladder cancer or some kind of urological lesion excluded. So that's maybe something that we need to discuss. But if they also had perhaps hypertension, a raised creatinine, and most importantly, if I see protein on that dipstick, that's what's going to make me think, actually, this is more likely to be a renal cause rather than a urological cause, and they should be off to see you in the nephrology clinic because I'm concerned that there may be some kind of glomerulonephritis. Rarely we may get patients presenting with gross nephrotic syndrome, so some leg edema perhaps, foamy urine, but I think most commonly we're trying to pick this up earlier, and that's the message I really want to give to my primary care colleagues today, is think about it. In those patients where perhaps you're seeing hematuria, check for proteinuria as well, and then consider IgA nephropathy as a cause.
This is something a nephrologist sees quite often,
Yes.
that patients that have hematuria and proteinuria have been first checked by a urologist, but I don't think there's a single urology disease that could explain proteinuria. So I think that's a good information also for our audience, that if on the dipstick there is protein along with hematuria, send the patient straight to the nephrologist. So as we mentioned, proteinuria, so does it help us also to stratify these patients? Does the prognosis depend from the level of proteinuria?
Definitely. So when we look at the data from the RADAR study, we can see that those patients presenting with the heaviest proteinuria were most likely to progress more quickly towards end-stage kidney disease. We know that those even with lighter levels of proteinuria still progressed, but less so. And so that can allow you, a specialist, to triage to make sure that you're intervening more quickly, and perhaps also make sure that I'm getting that referral in as quickly as possible with those patients presenting with the heaviest proteinuria.
Maybe you could illustrate us your procedure from one of your cases?
Of course, yes, I'd be delighted to. So let's pretend this lady's coming to see me in my primary care clinic. So we've got Julia, and she is a 35-year-old lady. She works as a school teacher, and she is presenting with hematuria, gross hematuria. She's noticed it in her own urine, which has become Coca-Cola coloured for the last few weeks. Prior to that, she had a sort of self-resolving upper respiratory tract infection. When we ask about other symptoms, she also mentions a little bit of swelling of her ankles and feeling generally tired over the last few weeks. So we get a few simple tests done in primary care, which we're able, of course, to easily access. So her blood pressure is a little elevated, certainly for her age, and looking back to her baseline blood pressures at 148/92. We do dipstick her urine, and she does indeed have hematuria and proteinuria as well. No leukocytes, no nitrites, suggesting any degree of infection. We get some bloods done, and her creatinine is slightly elevated, and her EGFR has dropped to 62, having previously been normal. So certainly I'm thinking here there are some red flags for a glomerulonephritis type cause. She's got post-infectious hematuria, she's got proteinuria, she has some decline in her renal function as well as those symptoms of ankle edema. I'm definitely thinking of a nephrology cause here. This could be IgA nephropathy. So my next step is to refer her to my renal colleagues.
Thanks, Sarah, to referring the patient to the nephrologist. I think the nephrologist would have a broader differential diagnosis of that presentation, and that's why we would generally advise for a kidney biopsy in that context. And for this, we have the kidney pathologist here. So let's imagine we did the kidney biopsy. What is your experience with these kind of patients?
Yeah, I have to be honest that we often experience that patients with IgA nephropathy, but also other diseases, come to us and receive the biopsy after running for a year or more with hematuria without having the diagnosis. So I just want to stress, even from a pathologist perspective, the importance to try to identify these patients as soon as possible and to refer them to the correct specialist, which might get even complicated the more we now know in medicine and, of course, in nephrology. What I believe is very interesting is that the prevalence of IgAN, I think we don't know exactly, because the kidney biopsy is currently the only means to diagnose this disease. And we know there are data that show that IgAN prevalence is actually dependent on how much biopsies we do. Mm-hmm. And that's because of the very wide clinical presentation. So I do believe that we need more biopsies to really understand which patients have this. And I understand I am biased as a pathologist, so I hope you excuse this.
So you mean to say some patients end on dialysis without ever having received the correct diagnosis that would be treatable early on?
I don't know the exact numbers, but we sometimes receive biopsies where it's written the patient is long-term CKD or on dialysis, and now we actually would like to know what he has because he might get a transplant. And there it becomes very important. What is the primary cause of the disease? Sometimes it's too late, but this is also not uncommon to have such a diagnosis of CKD, which is not a diagnosis kind of.
So what do the guidelines tell us?
Yeah, so the guidelines are very clear here, and the KDIGO guidelines confirm that IgA can only be diagnosed with a kidney biopsy. And also, I think this is also something we need to look in the future. There are currently no validated diagnostic serum or urine biomarkers for IgAN. So therefore, pathology remains the real gold standard here. And what is also important, and I think we discussed this already, is the level of proteinuria. So what we see is that you should rather broadly and more flexibly go for the biopsy, even though it's an invasive measure. Mm-hmm. But the added value of having the diagnosis or even excluding the diagnosis is very, very high. So this is an important aspect.
So let's go on with the example. Sarah introduced us to Julia, that patient with the hematuria proteinuria, and this is her biopsy. Could you comment on that?
Yes, so this is how a biopsy looks like in a native state. You already nicely can see here outlined in the bottom the glomeruli. That's where the disease activity is and how it looks like. Then next to that, to the fresh sample, you see actually how we look at it under the microscope in the so-called PAS stain, so that we see the morphology and what's happening there. And then you see on the right the main diagnostic criterion, and that's the IgA deposition in mesangial areas. And that's very typical. You can then also see in the ultrastructural analysis using electron microscopy, you see with the arrows, that's the bottom right picture, the electron-dense deposits of this IgA within the glomerular structure. And this is the basis of nephropathology assessment of a typical IgA case like the one from Julia.
So maybe for clarification, IgA is an immunoglobulin, is a normal circulating blood component, but when you see it in a kidney biopsy, it means deposition of immune complexes that activate complement, this causing the injury.
Exactly. And this is also what we see. It's not included in this picture, but particularly C3 is another marker that we would like to have in such a case, and that was also positive in this case.
Okay, so that means with kidney biopsy, the diagnosis can be confirmed, and then we could start treating this. But how else the kidney biopsy can help us stratifying patients to different levels of care? Maybe some patients could be handled at the GP level, others may need the university academic center kind of care. So how can we distinguish the patients and their treatment needs?
This is, I think, one important question. And as far as I know, we don't have any means to stratify patients to receive treatment at the moment. So not really predictive markers, but we have at least prognostic markers. And maybe one of the most widely used and validated is the International IgA Prediction Tool. And if you look at the parameters that you use to then predict the progression of the patient, then it's of course the major biomarkers that we have in nephrology, which is GFR, the glomerular filtration rate, then blood pressure and proteinuria, and of course age and race. But then if you look further, then there is lots of data from the biopsy that helps you to understand how the disease will progress. And this is what we call the MEST-C score. The MEST-C score is a validated score that quantifies changes in the biopsy that show you active disease lesions and chronic disease lesions. So for example, the more mesangial hypercellularity we have, the more cells in the glomeruli proliferate. This is pathological proliferation. That tells you how the disease is active. Similarly, also endocapillary hypercellularity is a very active lesion. On the other hand, we have segmental sclerosis, that is kind of fibrosis of the glomerulus, and fibrosis and atrophy, which show you how much chronic lesion, how much damage was there that was not repairable. That are the major parts that we look at on the biopsy that help us to understand the progression of the patient in the MEST-C score.
Thanks, Peter. That's very enlightening. So I have a question. We heard before proteinuria is one of the factors that should trigger referral and also kidney biopsy. But as a nephrologist, I know there are also patients that have chronic hematuria and maybe hypertension and still have IgA nephropathy. So what's the role of hematuria in all this? And do you have any numbers?
Yeah, there are some numbers, there are some data on this. And if you would just look in isolated microhematuria and look at biopsy findings, you would actually see that quite many of these patients have already even chronic lesions, because that could mean that the patients have flares and that you just pick the patient not at the flare. And then you see that this was ongoing for a long time and the patients already have chronic damage. But on the other hand, even active lesions like the so-called crescents, the extracapillary hypercellularity, are also quite often seen, even in more than 20% of just isolated microhematuria, which nephrologists would probably consider not a very malignant clinical finding, but on histology, we see these changes which indicate very progressive course, and at least to pathologists indicate very active lesions.
But having the chance to do a biopsy on these kind of patients, let's say hematuria and hypertension, no proteinuria or low proteinuria, would even give us a longer window of opportunity for intervention and prevent chronic kidney disease or progression of chronic kidney disease.
Definitely, and IgA is not the only finding in such patients. So there are definitely other findings that we can see.
Okay, Peter, thank you. So I understand the kidney biopsy is the gold standard of making the diagnosis and guide patient stratification for different levels of care. But as a clinician, I cannot redo a biopsy every year or so. So are there any other biomarkers that could help the clinicians to see activity of the disease or chronicity?
Again, I'm sorry that I'm biased as a pathologist, but you can redo a biopsy. And we know that from transplant, because we have protocol biopsies where it became clear that that might be very helpful. But of course, in GN like IgA, we don't have established whether this will really help. And since we don't yet, in my opinion, have predictive biomarkers that would tell how to treat these patients, then I also don't see that we should do this more often. And as the KDIGO guidelines suggest, we currently don't have any biomarkers to really look at and understand the activity of the disease. But there is lots of research going on in this area. And I believe there might be in the future some opportunities to have biomarkers or a set of biomarkers that might better help to stratify patients even for a treatment. But whether this might be some specifically altered IgA, which is involved in pathomechanism of IgA, the serum IgA levels themselves, or circulating immune complexes, or even in conjunction with complement levels, this could turn out to be maybe helpful, but we need more research to really establish these for the future.
Okay, Sarah, Peter, now we have arrived at the diagnosis of the patient. We have stratified the prognosis. of an individual patient. So now, who's going to take care of this patient? How is it going on? What is your experience, or how you would like it to be?
Well, I think from a primary care perspective, I would expect most people with IgA nephropathy to remain under at least some degree of specialist care. This is a rare disease, relatively. It's something I'm not familiar with seeing on a regular basis. So I would expect most patients to stay under nephrology unless they were very stabilized and there was a clear plan and communication around monitoring going forwards. But I think there's a role for shared care for many of these individuals. They will remain, of course, under primary care for all their other health needs. And so communication between primary care and nephrologists, I think, is really important. And I think that's something over recent years we've got better at doing. Speaking to our specialists, having means of communication. I think that can be really helpful, especially around these perhaps more complex cases.
And now we have also expanding treatment options. And I guess, Peter, as you said, maybe a rebiopsy sooner or later being done to decide which kind of treatments?
Maybe. I think that's the future. But maybe to get to your previous point, just a short example. I'm a pathologist, so I would like to have these patients with specialists. And even there, it should be maybe differentiated with what we really need. And one example is that if a young physician, I get him on the phone to discuss with him the findings on the biopsy, if this person rotates from another internal medicine or just started in nephrology, I have to spell out glomerulosclerosis. And I understand that he doesn't understand. So the communication needs to get to a level where people can truly interpret what information we have. And I believe similar discussion and education is relevant not only between pathology and clinical areas, which is very often the case, where we see that we need lots of discussion, but I believe similar needs to be between GPs and the specialists also.
I think specialists are always aware that they should not take away patients from the doctor referring them. But I mean, to some extent, I agree, because the treatment landscape of IgA nephropathy gets more and more complicated with new drugs arriving, some also quite costly drugs. So we really need to know which patient needs which drug. And there are also so many clinical trials now. And for many patients, participating in a clinical trial is the best option to get the new medication, or really to help to improve the treatment landscape for everyone in the future. So I think that's something that is new in the IgA domain. Didn't have that 10 years ago, and would argue for care, at least for a while, at the level of the specialist, that can work out the best treatment option for this particular patient. And of course, then we'll refer a patient back to GP if GP is happy to do that. For example, for the care of chronic kidney disease, because all patients with IgA nephropathy have chronic kidney disease. So what would a GP do if I tell, this is chronic kidney disease, please take care of that patient? What a GP knows about it?
Yeah, absolutely. And again, there is variation in knowledge and skill amongst primary care. We all see that. But chronic kidney disease is something we're pretty comfortable with managing. It's still challenging. There's lots of things we need to try and optimize, but around blood pressure optimization, around lipid control, around use of RAS inhibition, SGLT2 inhibitors, and so on. This is something we're increasingly confident with doing, I think. Again, sometimes in communication with our specialist colleagues, but that's something we're comfortable with. IgA nephropathy, less so. I think our role in this, in primary care, is that initial pickup, that thinking about this is a possibility, that checking the urine for hematuria and proteinuria, and just being aware of this as a possible diagnosis and when to refer to yourselves.
I have a question. What is your thought about screening? I mean, we have these dipsticks. They are pretty cheap and very easy to use. Wouldn't that be a possible option?
In my opinion, that would be ideal, of course. Then we could pick these patients up far earlier, well before they would present with symptoms. But the idea of doing a regular dipstick on all of my 6,000 patients in primary care is a huge workload burden. Remember, this is a relatively rare disease. And we're managing every disease you could possibly imagine in primary care. And I suppose for me, that would be just too much of a workload burden without indeed the evidence base for the clinical and cost effectiveness of that kind of screening program.
Yeah, I think the specialist dreams about screening here, but what it means practically at the GP level is a different thing. And I imagine with the dipstick, you would pick up a lot of other things that would induce secondary diagnostics, which we still don't know if this is more harmful or beneficial for patients. But I appreciate, Peter, your enthusiasm for IgA nephropathy screening. But I think we are already struggling with CKD screening in the population, and this is not so rare. Chronic kidney disease is considered to be 8 to 10% of the population have some sort of chronic kidney disease, and that may be actually valuable to screen for. And the test would be the same, a dipstick or urine analysis for albuminuria, proteinuria. And even this is discussed for cost effectiveness currently, but some countries are doing this and seems to be quite helpful. But I think in Europe and other parts of the world, opinions on this are quite diverse. But yeah, thinking of IgA patients, we would love to see them earlier to be able to treat them better. Absolutely. So we mentioned that coordinated care or interdisciplinary care is the ideal model for these patients, but I assume that will be quite heterogeneous in different healthcare systems or healthcare settings, even within a single country.
Oh, very much so. I think it varies hugely from centre to centre, country to country, and depends on the setup of the healthcare system. So, I think these are patients who will benefit from input from so many different people, from primary care, from specialists, potentially from dietitians, clinical pharmacists, our nursing staff, most definitely, of course. And I think that multidisciplinary working can be really effective, particularly when thinking about our patients and how they gain from those different areas of specialist care, but also that individualized care that they can perhaps get from people they're seeing more regularly and from allied healthcare professionals. Now that's ideal, isn't it? We know in the real world, it can be very difficult to obtain funding and to get all of these people involved in care where we would really like it. But yeah, that's the aim. That would be brilliant for these patients.
I would maybe add, because you now see the picture of the care coordination, pathologist is missing there. And if you think about it, there are parts of the world where there is no specific kidney pathologist in the country. So how do you want to do an IgA diagnosis if you don't have the tools and even the expertise? So this might be very different in various parts of the world. And I believe this is one important part. But of course, I am biased as a pathologist.
Well, to be aware of the gaps in infrastructure or knowledge, I think is the first way to try to find solutions. What is shown here, the interdisciplinary care by many different disciplines is certainly an ideal world scenario that may exist at some places with enough resources, completely impossible to imagine in other parts of the world, but it's the aim of the specialist to move on the field. And now we are understanding that patients could benefit from all of this. And we have to see what we can do in each of our settings, because as medications get more complicated and more costly, we really have to arrive at a kind of personalized care. And this requires also more sophisticated view on this. Okay, Sarah, Peter, thank you so much for this great discussion. I would like to summarize. I think we have learned that IgA nephropathy is a silent killer, and the late diagnosis is the main reason for the poor kidney prognosis. It would be very important to pick up these patients earlier, and this cannot happen at the level of the specialist. That happens in the clinic of the primary care physician that has to think about it when patients come with hypertension, hematuria, eventually also proteinuria, and this requires a urine analysis, so a dipstick or some other form of urine analysis. And there's no urological disease that could explain proteinuria, so please refer to nephrologist with that constellation. That's what Sarah proposed, and I fully agree. And then the nephrologist most likely will do a kidney biopsy, because IgA nephropathy is not the only possible diagnosis with this scenario. But when we do a biopsy, we often find IgA nephropathy. That's what Peter explained us. And there is the MES score and other ways to then make a prognosis prediction, which helps us to stratify patients to different levels of care. And I think we will hear more about the treatment options that are arising and have been developed and are now in part already available for such patients. So we really have to change our attitudes because the future is coming and we need to make sure the patients that need it get access to it. So yeah, this was great to have a shared discussion with a primary care physician and pathologist. Sarah, Peter, thanks so much for being here today and giving these important insights. And I'd just like to remind our audience to fill in the questions and complete the evaluation form to get the full credit for this activity. And thanks for participating and have a good day.
This program was presented by Medscape Education Global.